And our final speaker will be Dr. Hannah Slater, and she's going to talk about her ivermectin modeling to support field studies.
Morning everyone, thanks very much for coming. I'm going to be talking about modelling the impact of ivermectin. So my objective with this work was to bring together all the data that's been collected on ivermectin. So we've got pharmacokinetic data, data on the mosquitocidal impact of ivermectin, and we've also got data from Brian's field trials. So I wanted to bring all of this together to develop, parameterize and validate a mathematical model which can be used. Is that better? Which we can use to estimate the impact of ivermectin in a range of real-world transmission settings and under a range of different usage scenarios. So with this, there's three key questions to answer. Number one, what is the concentration of ivermectin in the blood over time? How mosquitocidal is this concentration of ivermectin? And how would this ivermectin, if given to a human population en masse, impact the mosquito populations? And then what knock-on effect would that have on malaria transmission? So there's quite a lot of things to think about in these questions. I'm just going to bring up a few of the complications. So how does the concentration of the drug increase? And then how does it wane over time? How does this vary based on the amount of ivermectin you've taken, and also the dosing regimen, so 1 day versus 3 days perhaps? And also, how mosquitocidal is this concentration, and how does this wane over time with the waning PK pharmacokinetics? And also, which mosquito species are we interested in? Where is this intervention being conducted? And in terms of the population modelling, we need to know what proportion of the population are likely to be taking the drug. Would it be used in combination with another drug, such as anti-malarial combination therapies? How frequently should the drugs be administered, and what time in relation to the transmission season? And finally, how would the drugs have different impacts in different transmission intensities and areas with different seasonality profiles? So first of all, we're going to look at the pharmacokinetics. So this is based on a model developed by Joel Tarning at Moru in Bangkok. This is 150 micrograms per kilogram, single dose, so it has quite a low maximum concentration, and by about 3 or 4 days, there's no drug left in the blood. Increasing this up to 300 and 600, we get a higher maximum concentration, but again, most of the drug's gone by about day 3 or 4. So people have looked at what would happen if we were to do 3 daily doses. So this is looking at the doses Menno did in his trial in West Kenya, which is 300 and 600. You're seeing consistently high ivermectin concentrations for about a week, and then the effect is lasting up to about 8 or 9 days. The next question is, how does this concentration of ivermectin relate to the mosquitocidal impact? So this is just some example data from Kevin from Anopheles dirus. So the data is all taken from where ivermectin has been mixed with blood and then membrane fed to mosquitoes. In the bottom corner of the graph, you can see the concentrations that have been fed to mosquitoes here. So we can link this back to the PK curve. If ivermectin has been given to a population, we can work out the average amount of ivermectin a mosquito would uptake on a given day post ivermectin distribution. So on day 1, it would take about this much, day 2, day 3, day 4. And then we link that to the concentration data, and then we can estimate the proportion of mosquitoes surviving after the ivermectin. So on day 1 after the MDA, we're saying pretty much all mosquitoes will be dead by about day 3. And day 2, this effect wanes, and then by about day 4, almost no additional impact on mortality, where the grey dashed line here is the mosquito baseline. Very usefully and interestingly, we've been able to analyse Menno's data very recently. So here we can get around having to go back to the PK curve, and we can just say directly, if a person takes this much ivermectin on this day, how many mosquitoes are going to die when they bite them? So confusingly, I've actually flipped Menno's curve, so now the quicker the line shoots down rather than up shows how mosquitocidal the drug is. So we try to model this by fitting an exponential decay curve to these data, and what we're interested in is the rate of decay of the combinations in comparison to the rate of decay of the grey line, which is no ivermectin. So from this, The important thing to note here is that we're very accurately capturing the proportion of mosquitoes that survive to 10 days. This is an important number to capture because it takes about 10 days for mosquitoes to become infectious once they take a blood meal. So with this, we're fairly confident that we are accurately predicting the proportion of mosquitoes that are going to become infectious. From this, we develop a hazard ratio. So this is the increased probability of daily mortality for a mosquito biting on a given day post-ivermectin mass drug administration. So as an example, a mosquito biting on day 2 would have, with the 300 micrograms per kilogram for 3 days, would have about an 8 times higher chance of death. And with the higher 600 dose, it would have about a 9 times higher chance of death. As mentioned already this session, important to think back to the PK curve we just looked at. In the PK curve, you're sort of estimating very little drug left in the blood by about day 7 or 8, but we're still seeing a significant killing effect out to at least 21 days, and it's actually still significant at 28 days. So there's something going on that we're not capturing with the PK here, which is super interesting to me and hopefully to you. And now we're going to look at what this would do in a human population. So I've saved equations for today, and I'm just going to be showing cartoons instead. So here we have a mosquito population and a human population. The mosquitoes are going to bite the humans. Some of them have bitten the people that are red. The people that are red have malaria, and then some of the mosquitoes are going to become infected also. It takes 10 days for these mosquitoes to become infectious. 10 days later, they'll go back, bite the human population again, and some of our humans are going to develop malaria. So now we ask, what happens if you give this population ivermectin? So here we've got 80% coverage of the population with ivermectin. The mosquitoes go on blood feed. Most of them will pick up ivermectin in that blood meal. Some of them might pick up gametocytes from the human, but importantly, they're all going to die before they get the chance to go and bite humans again. So when the next mosquito biting happens, no new people get malaria because there's no infectious mosquitoes in the population. So obviously this is a simplification, but hopefully a useful way to translate sort of a clinical perspective to a population perspective. This is actually a full malaria transmission. This is an ivermectin model incorporated within the Imperial College malaria transmission model. So it's got lots of complications in age, immunity, population structure, and I can talk about that in more detail if anyone's interested. So the first thing we want to look at is what would be the impact of various ivermectin dosing regimens on mosquito populations. So here we're looking at 4 different regimens. So the single dose 150, which is what Brian did in Burkina Faso, and then also looking at what would happen if you ramp this up, so either giving 150 for 3 consecutive days, or the 300 and 600 for 3 days, which are the doses tested by Menno in Western Kenya recently. So also, it's important to think about ivermectin in terms of the place you're going to use it. So we look at 2 settings, a non-seasonal transmission setting and a seasonal transmission setting. And what we're looking at here is the percentage reduction in mosquito abundance over the course of a year. As you can see, the impact is much greater in a seasonal setting. This is because you're targeting the mosquito population at the time when there are mosquitoes. If you just do it in a seasonal setting, then you've got a constant flow of mosquitoes coming in all year. So to do a 3-month intervention is only taking out a 3-month chunk of that sort of yearly force of infection. The next thing we want to know, we want to translate the mosquito dynamics to how this is going to infect people. So we're looking at now EIR, so which is entomological inoculation rate, which is the number of infectious bites that each person receives per year. You'll notice here that these numbers are bigger than for the general mosquito populations. This is because ivermectin has a preferential impact on older mosquitoes, so it'll actually shift the age distribution to younger mosquitoes. This is because it kills mosquitoes that have bitten, and in order to bite a mosquito, it has to be a couple of days old at least. So it's just a sort of a slow shift to younger populations. And we're seeing really quite dramatic effects on EIR. So with the high dose ivermectin, we're predicting an 87% reduction in EIR, so the number of infectious bites received by the population in a year. The next thing we need to know is how does this force of infections to humans translate to incidence? So this is clinical incidence in under 5s. I should have mentioned this earlier. This is a regimen assuming you're doing 3 rounds of MDA 1 month apart. So the arrows at the bottom of the screen here represent the monthly rounds of ivermectin. Again, you're seeing really dramatic effects on clinical incidence here. So in the seasonal setting, you're getting up to a 35% reduction in incidence, suggesting, which is perhaps a marginal reduction, but in the seasonal setting, you're getting an 83% reduction in clinical incidence, which is pretty dramatic. The final thing to look at in terms of malaria is the impact on prevalence. Again, in a seasonal setting, you're getting quite a modest reduction in prevalence because fundamentally ivermectin doesn't clear parasite infections, it just stops new infections. So it's going to have a very slow impact on prevalence. So pretty modest reductions in prevalence. This really highlights that ivermectin on its own in a high transmission setting isn't a suitable intervention to eliminate. What it might be more suitable for is either burden reduction or for use in much lower transmission settings where elimination might be possible, or in combination with artemisinin and combination therapy. Then you have the double-pronged attack of sweeping out all the parasite infections and then preventing any new ones from coming again. Important to note here also, I think the impact of ivermectin very much depends on the length of the transmission season. So the results we've looked at so far are quite an optimised setting. So we have a very short transmission season. And here the transmission season is about 5 months, and actually the ivermectin is preventing infections for about 3.5 months of this. So it's a pretty big chunk of the transmission. The plot on the right is a seasonality setting from Burkina Faso. It's got a much longer rainy season. And then doing your 3 monthly rounds of ivermectin is going to have a much reduced impact unless you do it for the whole season. So putting some numbers on this, in the short season, the high dose will give you an 87% reduction, but if you have a longer transmission season and you're not treating for as much of this, you're going to be getting a 59% reduction based on the model. We can think about this idea in terms of some work that's been done already for seasonal malaria chemoprevention. This is some work done by Matt Cairns at the London School. This is a map of the proportion of rainfall occurring within a 3-month window. So basically, the hotter the colour, the more shorter and sharper the transmission season is. So similar to SMC, areas that have short, sharp transmission seasons might be more suitable for an ivermectin type intervention also. Finally, we're going to look at some of the, we're going to use the dosing regimens that Mena used in his trial in Western Kenya to see what impact that would have on a Western Kenya type transmission setting. So here we look at doing a mass drug administration with ivermectin plus dihydroartemisinin piperacin, 80% coverage of the population, and assuming a Western Kenya seasonality profile, and very, very high transmission, so 30% prevalence by microscopy, which would probably be about 60% by PCR, so super high. And it's assuming 2 rounds of MDA, 1 month apart, and continuing for 2 years. So the interesting comparison here is between the dashed grey line and then the coloured lines. So you can see that adding ivermectin increases the impact of the MDA and really suppresses transmission in the months after the MDA. This effect would be even more pronounced in a low transmission setting, and it would potentially get you to very low prevalences where local elimination might become possible. A similar result is noted for clinical incidence. If you look at the difference between the grey dashed line and the coloured lines, you're seeing that adding ivermectin onto your mass drug administration will have a massive effect on reducing incidence. Interesting to note that even though the difference in the mortality between the 300 and 600 regimens look pretty big from the clinical data, in the modelling it's actually not much difference at all. This is because they're both just killing mosquitoes a lot, so it doesn't really matter which one you go for. The modelling would probably suggest 300 might be the one you want to continue with because it's almost as good and would likely have fewer safety concerns. Finally, I'd like to mention some long-lasting formulation work that's been going on. So as you've seen from the modelling, long-lasting ivermectin is really, really good. So a few groups from around the world have been looking at whether you can develop new long-lasting formulations. So one of the options has been compounds that have considerably longer half-life than ivermectin, but also have this mosquiticidal property. A group at MIT has been looking at a delayed gastric residence dosage form, which is a sort of magic polymer starfish that goes into your stomach and stays there for a few weeks, slowly releasing slow doses of ivermectin. And also Carlos has got a very interesting paper in the Malaria Journal on ivermectin implants. A lot of these products are very far from implementation stage, but they're super interesting, and hopefully the modelling can show that they could potentially be really impactful. So I'm just going to talk a little more about one of these projects. This is in collaboration with colleagues at TropIQ in Netherlands and Caliber in San Diego. They found these 2 drugs which are currently given to dogs, solely used in veterinary medicine, currently not licensed for humans. They have a super long half-life, so they last at mosquito-killing concentrations for a really long time, about 2 months. So we've done some model simulations to try and have an estimate what impact this would have on malaria. So we've taken a conservative and an ambitious a range of mosquito killing duration of 43 and 72 days. We've simulated this in the model. So we've assumed that you're giving a mass drug administration with dihydroartemisinin and piperoquine and a 43 or a 72-day mosquitocidal drug indicated by the blue and the pink lines that's about to come up. Seasonal transmission setting, 80% population coverage, and repeated for 2 years. And as you can see here, the DHA PIP on its own clears out the parasite infections, but then transmission rebounds very, very quickly. Adding on the high dose or the long-lasting mosquitocidal drugs, you're getting a really sustained reduction in transmission. And importantly, this pink line here is getting to very, very low prevalence for very, very long time. So this is the sort of time that you might be able to achieve a local elimination of malaria in a low transmission setting. But pop some numbers on this. So with the DHA PIP alone, we're estimating 64% reduction. Adding on top of this the long-lasting mosquitocidal drugs, we're seeing this goes up to 84 and 95% reduction in ivermectin in incidence. So pretty exciting. I hope you agree. So finally, to conclude, modelling indicates that mass drug administration with ivermectin could significantly reduce malaria burden. If used alongside an ACT, it could sustain the gains of MDA and continue to suppress transmission in the months following. It's particularly suitable for areas with a short transmission season, where repeat MDAs can cover the whole season. And larger doses of ivermectin have a longer than expected mosquitocidal activity and are predicted to provide a powerful additional intervention to help towards malaria elimination. I'd like to thank many people who have helped me think about all these ideas, and it's a truly international effort. Email me at the bottom if you've got any questions. And finally, I'd like to point you to some of the ivermectin work that's being presented at this conference. Thank you very much.